I wasn't confident I could do all this and still be able to do a nail, which was going to be my plan A, but I could also abort at that stage and go to plan B, which would be to fix this with its own implant, a blade, and then come back and address the shaft somewhere else.
Sorry to interrupt you, but Mike, so set it up for the audience. Are you on a fracture table? Are you free? Where are you? How are you getting your lateral of the femoral neck?
So we're on a radiolucent flat top table with a bump, and patient supine. The lateral imaging of the neck is challenging at this point, particularly until you can manipulate it as a block, which you see here on the image. But you have visual and palpable, as well as AP and oblique views. So you pay a little price not being on a fracture table to image intraoperatively laterally without rotating it, but you gain, particularly in these young people, so being able to support this floppy leg rather than hanging it in traction, to me was a reason to do that.
And your surgical approach, Mike?
It's just basically a lateral approach with the option to go into a Watson-Jones. I'll just show you this and then we can go back. But so this achieves a reduced proximal segment, but it's obviously relatively unstable with just pins. So we exchange that for a single screw. And then if you look at this extremity is AB ducted to get this reduction, obviously to bring your trochanteric down. But now that you have that as a unit, you can AD duct, which you will need to do if you're going to place a nail. And so what you see on your right is a stout Steinmann pin that's going from anterolateral, avoiding the intramedullary canal, but entering the lateral aspect of the base of the neck, going into the head. And that gives you the motor or the wrench to AD duct the segment and then actually skewer it to the acetabulum. And that gives you stability. So now you've got a stable proximal segment that's in an adducted position. And that allows you to continue. And this is you asked about the approach, and I hope you can see it here. This down here, this little line, that's the only bone we're seeing. That was a elevated and anatomically reduced greater trochanteric segment that allowed us to get control of the segment with the Weber clamps and then fix it with those pins. Here you see this here held that way and then positioned for the guide pin and ultimately intramedullary nail. So this
Mike,
sequence of steps. Yes.
What I'm excited to talk about is the blade plate. So for practitioners out there who aren't as familiar with the blade plate, they hear a lot about it. They, there's almost like this mysticism about the blade plate, and what do you think? Can you give me some thoughts about why is there such a fever about the blade plate? It's a tool, but there are devotees, and maybe you could sort of get into your thoughts with regard to the blade and when and how you use it.
The blade plate is a remarkably simple, old, yet unbelievably powerful tool, which maybe just by luck, but it really has proven the test of time. I'm no master with it, and I've learned more from you with this than certainly the other way. But unquestionably, the ability, the rotational stability, the protection of bone, the blade does not remove any bone. So and the power you get with it is really, I don't think, is still, there's nothing comparable. The lack of stress concentration, all these interlocking devices now, the locked plates, such stress concentration, you either get too stiff or you get early fatigue. None of that really happens in the blade. It's a really, really powerful tool. A fantastic intraoperative wrench. So those are all the advantages. It's challenging to use. You really, if it has really no reason, you can't miss. If you put it in incorrectly, it's going to be bad. So certainly in the settings of non-unions and up in the proximal femur, very, very powerful tool. I'm certainly not an expert at it, and it's a great tool, and
I think
sad to see it go.
Yeah, I think it is a really powerful tool, and one that few of us really have mastered. Where do you think, and talking to the educator in you now, where do you think the education of a blade plate fits now when you look at the spectrum of the courses? Because you have oversight over these things and you realize the value of this tool. Where do you see that fitting in?
Yeah, I mean, honestly, I think the blade is a required learning for those that are going to be doing tertiary and people are going to be sending them in non-unions and places where there's just minimal bone available. In the setting of acute fractures, I don't see the typical current or future surgeons going right to a blade plate. It's just, there's other options for most. But in the setting of revisions and, particularly in the proximal femur, it's got a place for sure.
Great. Well, thank you. So let's get back to how you manage this particular case. So this is pretty good. So this is a bifocal proximal femur fracture. Many people would be thinking 2 devices. You chose 1 device. Can you tell me why you thought that would be the best thing to do in this particular circumstance?
The main reason is that this was not a particularly distal shaft fracture. And so I really would be, I would be limited to try to do, to fix that with intermedullary device and then a plate on the other way. And I do like he had a broken arm that we had to manage. I do like the fatigue strength of the nail. And like I just said earlier, in the setting of acute fractures, I would have trying to hammer a blade through a broken trochanter, through a broken neck, into a 42-year-old head of the femur. That's a procedure that I could really mess up. I could blow it all apart. So although some people really could easily do that, I would struggle. This clearly is not a case for a DHS. And so I thought if I could do an anatomic reduction of that proximal segment and then put an intermedullary to cephalomedullary nail in it, it would really be helpful. I was prepared to do something else, but this was clearly my first choice.
And a good one. It's, like I said, not easy to do. Maybe you can proceed to some of the next slides and show us what you...
Yeah. So this is the bigger picture, and what you can see, again, is the open reduction, but that the majority of this reduction is all done indirectly. In this case, with the universal distractor. And you can see at the top, really at 9 o'clock, you can see the entrance of the guide wire for where the nail was actually to do. So the first, again, it's the sequence of steps, that whole first part of reconstructing the proximal femur. The last thing you want to do is have this femoral shaft in traction because you want the instability of the fracture to allow you to reposition the trochanter and the neck anatomically. But now once you've done that, now you go to the step, well, geez, I got to get length for that shaft fracture. And once you get length with the distractor, you use the 2 joysticks to reduce and place the guide wire for the femoral nail. And that's just what you see here.
Mike, where are your Schanz pins?
The Schanz pins are right the joysticks are basically in the anterolateral shaft of above and below the segment. The pins for the fixator, I think one of the end pictures you'll see it. The distal one is off axis from the canal in the femoral metaphysis. The proximal one I chose to put in the anterior inferior iliac spine because, of course, I don't want to load the proximal femur, so I'm going from pelvis to distal femur on those pins. So
very nice.
Okay. So yeah, it worked out well, and this is what you're seeing intraoperatively. Is what this, so you've got your shaft shish kebabbed, you've got your head and neck segment fixed and stable to the pelvis. And what you don't have is the alignment of the femur, either at the subtroch or at the shaft level. I mean, the nail's down, but you can still dial it in. And here's the power of this stage: is you've got distraction from the pelvis, and I can distract out the femoral distractor to dial in my neck shaft axis. And here you can see we're kind of gapped, and then I can come off to put that neck shaft within 5 or 8 degrees variation of where I want it. And one of the things I really like about nailing, at least in my hands compared to plate fixation, is when you select a nail that's got 130 degree alignment with its cephalomedullary fixation, I mean, this is your report card for what your neck shaft axis is, and you're finding this out intraoperatively when you can still change things. So when you see the 2 drill bits going up into the head and neck, you just know you either have or don't have a satisfactory reduction. And so you can dial in that neck shaft axis to achieve that. And this obviously stabilizes your subtroch component. And then, the shaft, you check rotation. And this was, actually, I only saw this guy twice. The images on the left were at 6 weeks, where he clearly was in the process of healing proximally. Hopefully, I think his shaft looks like it was on his way. On the lower right-hand picture, you can see where the screw was, where the distractor was distally. So anyway, I think for me, this just shows a lot of different ways that you use both direct and indirect reduction. But most importantly, you look at the sequence of steps. Like, not any one of those steps was particularly challenging, but each one came at the right place and in the proper sequence to go, like MAST would teach us, from a little bit of reduction, a little more stability up the channel. That's why I thought it'd be a fun case to show, because it brought that point home to me.
Sure, and I think, but this is a daunting case. I think for even the most seasoned trauma or fracture surgeon, this would be a case that might get them get their gastric juices flowing, I should say. And I think that the result is excellent, the alignment is excellent. When I think about nails in the proximal femur, I think about essentially a diaphyseal implant that we've extended the indications up into the metaphysis, and that's when you start extending indications. That's when you start getting into trouble. But clearly, you've mastered this whole process when you deal with your proximal femur fractures, either in young people or old people. Now, when you go back and look at those screws, great position there. Can you talk to me a little bit about do you think about tip apex distance for 2 screws, or is just with 1 screw? And then we'll talk about that a little bit more.
I think the difference between 2 screws and 1 screw, no, I don't think that makes a big difference. I think the whole, this TAD thing, the bottom line is, as you get older and you lose bone density, the only thing left is your primary compressive trabeculi. And in order to have a foundation for implants, in the proximal femur, you have to put your implant deeply into those primary compressive trabeculi. And that's dead, that's deep and center. So any of your devices, be they 2 screws or a single screw, in the setting of these high bending force trochanteric fractures, that's where you have to be. You bypass the hollow neck and you gain access there. And anything that's not central obviously introduces its own rotational forces around that. And so in this case, I wasn't thinking so much TAD. I was much more thinking these screws are proving that I've got a good neck shaft access, and that is going to heal this fracture and make him have a very functional mechanical proximal femur for the rest of his life.
Hey, I'm going to ask you, Mike, to go back on those x-rays, if you don't mind, and just show us with regard to your entry point. Maybe you can point out with regard to your entry point, your thoughts with regard to where you put the entry point, and maybe you could discuss this concept of the trochiformis starting point, which is a sort of a unique word, but maybe you can give us your thoughts, Mike.
Yes, I'll just, maybe I'll say bluntly, I have one indication for using, if I have the option between a piriformis and a trochanteric start, my indication for the trochanteric start nail is when I mess up the proper entrance site and I accidentally go too lateral, I'll go back to this device. But I believe that particularly as the patients get older, an entrance site that is at the tip or slightly medial to it is preferred for many reasons, but not the least of which is it really helps you avoid a varus neck. To me, it's easier because it's an easier landmark to identify. It's particularly helpful in the geriatric world, and I think there's some cases later on that I may bring this up. But if you don't remove a channel of bone at the tip or slightly medial to the troch, then you have no ability to dial in an effective neck shaft axis in these geriatric fractures. And if you try to achieve a valgus angle, what you'll end up doing is pulling apart the medial cortex, which doesn't help them in. I don't know if that answers it, but I really think that entering slightly medial gives you a safety factor that you don't have off axis.
Right. It just and again, it adheres to the dictum of "Thou shalt not varus." Right?
Yeah,
so
absolutely.
Maybe we can go on to those cases that you discussed.
Okay, yeah, we'll do this. This kind of just jumping gears from a fairly somewhat complex. I show this case because it seems so simple, and in many ways it is, but I've been burned by this in the past, and I kind of found a nice little trick to solve it. Maybe many people know it, but if you look at this geriatric fracture, I'm highlighting the fact that you just see a kind of a double density on the medial fracture line. And if you look at a good lateral, you see the reason, because the head neck segment has essentially fallen in to the shaft segment. And as I learned way too late in my career, it doesn't matter really how fragmented a geriatric intertroch fracture is. With almost no exception, the anteromedial cortex fails in tension. So it's a simple fracture line. You can have huge posteromedial segment, you can have fragmented greater trochanter, but the anteromedial segment is a tension failure. So if reduced, it will resist compression. And so the technique is to basically treat this almost like a Kapanji technique to reduce it, because at least at my institution and in my hands, a fracture table, a crutch, nothing actually corrects this easily. Introducing some sort of lever to simply lever into the fracture and then angle it to achieve a reduction is very helpful. And now you actually have a stable pattern. And here's this that same case just shown from the AP view of this double density to restoration of the medial cortex, and then you can really, you can fix it sort of any way you want. You can apply this lever either percutaneously or limited open. This is a little more subtle on the presentation, but interop, you see the exact same thing. And the first picture we saved was because we'd struggled for a long time trying to pull that out. But you can just see this technique of levering that into position and then holding it that way, and then with an assistant, you'll stabilize this. And in this scenario, the stabilization was such that we could proceed with nailing. And this, I just leave it here. You can see that little amount of collapse of this device tells you how stable the reduction was because you lined up that cortex. And if you look on the lateral aspect on your right, look at posteriorly how that was a very fragmented, and you can see this robust callus posteriorly. But anteriorly, you see, some retroversion, but notice how there's no collapse anteriorly because you restored that cortical buttress. So I just, it took me too long to learn this, and I think all the credit for, and basically I read this and then started using this technique, came from Jim Carr back in the early 2000s, and Jim passed away at a very early age about 10 years ago, and so I always make a point to bring this out because it certainly helped me and a lot of my patients. I don't know, Mike, do you use this technique? I find it helpful.
Yeah, I've used it, but not so much in the proximal femur as much as elsewhere. I think the concept that sort of resonates with me in this particular situation is trying to restore stability, not make the patient implant dependent, but making them bone dependent. So getting it so that you get a good reduction and the patient, it stabilizes. So almost as if your reduction protects the implant. And that's what I like about that. And that'll make a durable implant, a durable construct, I should say, and for the patient, and actually much less pain. So I really like that. You have another trick in your bag you want to show us?
The other thing is entrance site, and this is one that I learned the hard way. And this picture is probably from the 80s, and it was the typical way we would set up all of our proximal femur nailings, just like when we do a side plate, except you'd have to adduct the extremity. Now, the real advantage is the great fluoroscopy you get with this, because you have that hip, that other leg completely out of the way. But the disadvantage is if there's no counter traction on that well leg. And so the harder you pull, the more you simply rotate the pelvis around the post. And, the patient doesn't look like they've moved any, but it's amazing how much their pelvis is now getting in the way of what you're attempting to do when nailing. Now, if you're doing a side plate, it'd be no big deal because you put the leg anywhere. But here you can see what you're attempting to achieve, but with too much traction, the pelvis rotates to the point where you can't gain entrance where we want, slightly medial to the tip of the throat, but you certainly can get out in this lateral area, which then, as you can see in this picture, and now look where the screw is located in the head, and you can see just medial to it all of those primary compressive trabeculi that have never been touched. And this result, I think no one is surprised to see the rapid failure of this. There's lots of different solutions, but this actually was, I had to be kind of educated by my junior partners when they said, just extend the leg, or you can either tie it to the other leg or to the frame. but by extending the well leg and adding some typical flexion to your the fractured leg, you'll get pretty reasonable lateral x-rays, and you'll completely stop this problem of rotation of the pelvis. So, regardless of your table, this scissors positioning is certainly what I've learned kind of the hard way to manage for the last probably 15 years now. I find it very helpful.
That's great. Thank goodness for junior partners, right? They'd come in and sort of help us out.
Yeah, so true. Yeah. I mean, I shouldn't even be giving this talk. It should be my partners up here giving the talk, because that's what's great about surrounding yourself with bright people, and wherever you guys are out there, do your best to get in a group where your partners are smarter than you, because it's just every day it makes it fun. And this was Natalie Casimir taught me this, I don't know, 10 years ago. Like, duh. Anyway.
Oh, that's great. What do you think? Do you have one or two other tricks for us?
Let's see. I think most people, let me just buzz through this. This joysticks, and everybody's doing this, but what I find funny is when my residents come in and they just want to get a reduction, and they'll be pulling and pushing, and they're only focused on getting the fracture reduced, and they can perfectly get it reduced, abducted and externally rotated, and then you wonder, well, how are you going to put the nail in? So again, it's all sequence, and your first step is always entrance site, either retrograde or antegrade, and it doesn't really matter what the fracture looks like until you have achieved your reduction. So this idea of figuring out your sequence of steps, and here's a case from a long time ago of a hyperabducted proximal femur, also with the shaft, but the same idea. There's just no way to gain entrance to that and until you can actively improve it. And here's what you saw in that last case: joysticks in different orthogonally positioned to correct flexion and abduction, and then skewering it again. And when you have the fracture reduced, nailing it is very straightforward. So you can see the sort of flavor.
Yeah, and I think Mike. I think I'm sorry to interrupt you, but you were the one who you were the one who taught me that was to. The tendency these days is for folks to go ahead and open up a proximal femur, fillet it open, try and get control of that proximal fragment, and that's fine if that's what you need to do. I think as time goes on, you can accomplish the same goals by using smaller techniques, being less invasive, and I think what you've shown there is that it can be accomplished very, very elegantly with very small incisions, very simple implants, minimal blood loss. So reducing that proximal fragment, and then back to fundamentals, right? Reducing the distal fragment to the proximal fragment, now that you've got the proximal fragment in a reasonable position. So I think that's very, very elegant. I love the fact that you use the old femoral distractor. For those of us who are old school, I love that. It's a neat thing. The last thing I'm going to ask you to talk about is, I know you've got a cerclage case. Why don't you show us that? You have that trick?
Sure. Yeah, I may have to buzz through a few, but for those in the audience, I hate to say this, because I'll tell you, in the last 5 years, I think I've bought 4 of those distractors on eBay, and I've given them to my junior partners. So I have a search out there, that my rep, every time one pops up, but I love it. I mean, it's too short for certain things, but I use it at least twice a week. There hasn't been a plateau in 20 years that I haven't had that on. So, but anyway, you guys don't need it. You can get that big huge one. Save the ones on eBay for me. All right. Let me.
So one of the reasons, while you're clicking through, one of the reasons why I want to ask you about this cerclage business is because now, for many years, there was this very negative attitude with regard to cerclage. Cerclage was the tool of the devil. Cerclage was evidence of a struggle. And really, that's not the case anymore, right? So the minimally invasive group with Tirachai and others, Pietro Ricconsoni, others have shown that this is really a reasonable thing to do. And why don't you give us your take on how to apply a cerclage in the proximal femur?
So yeah, Mike, well, we're almost from the same generation, but I used maybe 2 cerclages the first 15 years I was in practice, and I'm sure both of them I cut and removed before leaving the OR, just because it was considered such a bad thing. And I still don't think I don't think I've ever used 3 in the same case, but as a intraoperative tool, particularly for a spiral fracture, it's just spectacular. And here's an example that you see: simple fracture, very displaced, lots of surface for healing, but you got to get it there. And so here you just see the sequence again, these singles broken down into single steps. The first thing you do, you pull on it, and that looks pretty good. And then you add the ball spike, and that looks really great. But how are you going to do a whole case with the ball spike right there? It's a bit of a challenge. So a single cerclage to hold, you only need the power to hold the reduction while you do the rest of the case. This is the tool that is certainly most elegant, although you can still be pretty darn minimally invasive even if you didn't have this. And I don't know, on my screen, this is actually a video. I don't know if any of that shows.
It's showing very nicely. Yeah,
oh, okay,
looks good.
Well, that's great. So that's a quick version of how you actually put these 2 pieces together and safely get around the bone. And then here is passing the guide wire. And this would be the biggest size I would ever use, because you just don't need a lot of power. You need the ability to twist it safely without breaking it. And then this is just disassembling it here.
Again, very elegant, very sexy.
So what that does, here you can see the fractures in varus. It's a little bit short. And you could use a Weber pointed clamp, but remember this is a 75, 80-year-old person, and maybe some fissures in that bone, and you put huge forces. I love the Weber clamp. I mean, I got 5 in my personal kit. But here you run a real risk of splintering it, whereas the cerclage, it protects, and you tighten it a little bit, you get out that push-pull, you twist, you put a little traction, then you tighten it a little more, do the same thing, and you're patient. Let things stretch. The more it's always length. So ultimately you pull it just enough and twist it just enough, and it clicks in, and it's just a few more twists on your cerclage, and you've got a really atraumatic, protected reduction of your fracture. But you're not done. And again, you're not look at the abducted nature of that extremity. And if you try to adduct it, you'll just pull apart your cerclage. So again, you can see the theme here. Put a big, get your strength with the joystick and adduct with the joystick and let that cerclage just kind of swing with it. And now the guide pin shows you that you've restored the right direction to gain the proper entrance. But that's not the proper entrance. So you're going to move it over where it ought to be. And if even I can take a non-displaced fracture adducted with the right entrance site and fix it. And so here you see the implant going in with the guide wire. And it's a simple fracture. You reduce it, you put a nail in it, it's going to do pretty well. So that to me is really the most perfect indication. There's other indications. In terms of cerclage, just so it's clear, I think it's completely, to put like 3 cerclages around a short oblique fracture, or put anything really near the center of the fracture makes no sense. It doesn't really give you much mechanically, and it does kill a lot. And so just like fractures, cerclage it's the devil's in the details, and you can't. It's not right to say they're horrible or great, but boy, for spinal fractures, I think a big improvement.
Absolutely, and I think I agree with you completely. One cerclage tastefully done, placed, very, very nicely with minimal disruption. You're using an indirect reduction implant, your nail, and the cerclage just facilitates that. You're really not disturbing it too much. So I agree with you. I'm definitely a fan, and I really like the way you've used that. So, we've seen this afternoon is a series of very complex cases. Again, Mike is extremely humble. He's shown that he's been able to master these cases, show you how to do it, and execute it in a very, very fine way. Definitely another level of invasiveness, very minimally invasive. So maintaining the blood supply, which always one of the basic AO tenets, and getting the stable reduction, so you have functional aftercare, and really well done. So Mike, thank you for your time. That was really an outstanding display of surgical expertise. We really appreciate your time. And thanks everybody for your attention. Mike Miranda signing off on AOTV.
Thank you. It was, Mike, as you know from the heart, this was a pleasure, much as I wasn't too fired up about it. But so anyway, yeah, learn. Mike said it very well. You really, in the OR, be patient. Guys are so hurried to just pull the thing to reduce, but go with the flow and good things happen. Anyway, I hope someone enjoyed it, and look forward to seeing some of you at some point in the future face to face. Be well. Thank you.
Cheers.
Cheers.
The COVID-19 pandemic has impacted every area of our lives over the past number of months. It has been incredible and inspiring to see how people have pushed through, risen to the challenges they've faced, and how they've found a way through this really difficult time. Well, determined that teaching and learning doesn't stop, those in education have diversified, and this is certainly true for the team at AOCMF. I caught up with Sabine Giro and Marcelo Figari to tell us more.
Hello, Hannah.
Hello, Hannah. It's a pleasure being here.
Sabine, can I start by asking you, tell us what the response was when you found out that the courses would have to be cancelled?
Initially, of course, it was a huge shock. But then, I'm the chair of community development, and we had actually already talked to the members all over the world, and they were very interested in having small group discussions within an online format. So we had already started with study clubs in Argentina, in Manila, in Cairo, all over the world. So we actually already had some experience in online teaching and online learning, where we would get together in a small group of people and discuss cases together. So we were able, after the initial shock, to hit the ground running and build up very fast on our experience with the study club. So what we did, we used the study club experience to expand this experience into a completely new online campus format.
And it's certainly been popular. You've had 20,000 participants join you online for courses. Marcelo, how has that worked?
Well, you know that after the initial shock that Sabine has already described, all the people were really very, very shocked for the clinical situation, but also because they lack for scientific and academic opportunities. And I think we were able to, combining the efforts of the Community Development Group and the Education Commission, to offer them a very high quality academic offer, and they were able to follow us and to improve his skills following the different activities that we brought them.
And Marcelo, what feedback have you had?
Well, the feedback was, as you know, fantastic from the very beginning, not only because so many people attended each of the activities and they were really very active participants, but also because of the messages and the evaluations, assessments we received. So we did all this feedback encourage us to continue and to really not only having what spontaneously came from the different members of the AOCMS community, but also to program really an online campus activity. And this was the big success until today.
And Sabine, can I ask you then, what are the secrets to your success? Have you had that kind of feedback too?
You know, I think initially we also, you know, we are really listening to what our surgeons want. Yeah, so we really asked them, what do you need? And it was very clear that they want to have sort of, you know, this interactive, immediate sort of discussion. So discussion is really one of the central things. The interactivity of our courses and our activities online is really the central part that what we are doing. I think the other thing that really hit us off in the beginning was that our team was very flexible. So we actually started doing a format that's called Frontline. And in this format, we brought thousands of surgeons together to talk about COVID. You know, we had people in, you know, Argentina or North America who weren't hit by the pandemic yet. And at the same time, you know, the Italian hospitals were filled with patients. So, or in China, in Hong Kong. So we brought, you know, our colleagues from Hong Kong together with our colleagues in the United States, in other countries, to tell us, you know, what is going to happen to us in the future. And I mean, in these meetings, we had up to 1,000 people in an online meeting. And of course, you know, technically that was very challenged, but it was so amazing to all of a sudden bring people together in response to this pandemic. And I think everybody was completely overwhelmed and happy to have some experience from people who already went through it. So I think that was really the sort of the starting point of this amazing program.
That is incredible collaboration. I can't imagine doing a Zoom call with 1,000 people.
I couldn't either.
There is, of course, nothing quite like face-to-face learning, but do you think that online learning will now be here in some form, potentially actually opening up opportunities for surgeons, Sabine?
Yeah, I think, you know, it really opens up for surgeons, for opportunities for surgeons in areas where they don't have, you know, the access to learning that a lot of us have in the developed countries. You know, I remember I was talking to a surgeon from, you know, Egypt, and she's about 80 miles south of Cairo, and she is responsible as a sole oromaxillofacial surgeon for 3 million people. She cannot just go next door and ask a colleague to how to, you know, do a case, or it's very difficult for her to travel because, of course, she's needed where she is. But she can participate in online activities. She can call, you know, online in our Facebook groups with case discussion, post a case, and within 15 minutes, you know, get a response from a surgeon or from more surgeons than she probably needs, and get some advice to how to work with this case. And, you know, these things will stay. But of course, face-to-face is the heart of our AO, and we are all looking forward to going back to that.
Oh, 100%. But Marcelo, what are your thoughts on this?
Well, I think that also the taking into account all the negative aspects, we should also consider the positive aspects of this pandemic. And this is that it motivated us in order to test the online activities more than we planned originally. And this will certainly stay. And we are now really reflecting in all our activities what should stay face-to-face and what really is better delivered via online. And many of our offerings will certainly change. Of course, will be a blended form in order to continue providing high-quality education.
Well, it's amazing how everyone has responded. Congratulations on all the great work that you've done, and enjoy the courses this year. Thank you so much for joining us on AOTV, Sabine and Marcelo.
Thank you so much, Hannah. It was a pleasure to talk with you.
Thank you, Hannah. It was a real pleasure to be here. Thank you.
Next, let's find out about an exciting opportunity and innovative program for the global community within AO Vet. Mark Glyde from Australia is the chairperson of AOVET for the Asia Pacific Board, and he's here to tell us more about the Clinical Research Symposium. Hello, Mark. Great to see you. Fantastic to have you with us. So this is a first for AOVET. Can you tell us a bit more about it?
Sure, Hannah. Thanks for having me on. This is a first for us, and it really comes from us recognising that there was a gap in the transfer of knowledge between the research and the clinical practitioners, our vets in practice. And certainly there was a delay in the transfer of this knowledge. What we recognised is that veterinary practice is different to human surgery in that most of our members are vets in general practice. So they're not in structured training programs, they're not specialists. And so they're not being exposed on a structured or sort of regular basis to cutting edge research. And so very often there's a delay in the research being done and then presented at meetings and finally published. And so we wanted to really bridge this gap and connect our practitioners, the people at the coalface who are doing the surgery on a day-to-day basis, with clinically relevant, practical, transferable research that can make a difference.
And how has COVID impacted this gap, would you say, Mark?
Well, it's really amplified this need, I think, Hannah, in that all of our scientific meetings have been cancelled this year as all around the world. And so that's meant that even for people who are in this research field, this area of clinical research, aren't getting to those meetings. And so this has really just amplified that need to communicate and do it in a virtual way to make these connections. So COVID has really driven this more quickly than it otherwise would have.
Now you have two symposia. You have a small animal one and equine. So how did this come about? Why two?
Well, that's a really good question, actually. When we have 4 symposia, and our original plan was to have 3 that were small animal and 1 that was equine. And that was really based on the number of courses we run around the world in small animal and a smaller number in equine. But what we found, I was actually quite astonished, when we called for abstracts, there was a tremendous interest in the equine area, and really just the sheer number of equine abstracts that came in demonstrated to us that there was this great passion and this great need in equine. So we've ended up doing 2 of the symposia on small animal and 2 on equine, which has been great.
And how does the format differ to maybe the conventional way of doing things?
Yeah, that's really interesting, and it really reflects the need of the audience. So in a typical scientific congress where a research abstract is being presented, the focus is very much on the research methodology and the specifics of that piece of research in great detail. And the difference in these clinical research symposia is that, yes, the science is very important, that's the foundation, but we were really looking for the key take-home messages, the transferables, that how can this make a difference? How can this piece of research change or inform the way that people practice on a day-to-day basis? So the focus was very much the context of this research. How did it fit in with the knowledge that we have now? How can it make a difference to practitioners to improve their patient outcomes?
I understand that most of the submissions have been grouped under 2 main categories. So can you tell us more about this?
Yeah, they've really been grouped into, if you like, joint diseases, Hannah, and into biomechanics. And I think this very simply reflects the clinical focus. And again, this is all about clinical research. So it reflects very much the questions that are asked on a day-to-day basis, it reflects the knowledge gaps that we have. And so for most of our faculty and our residents in training programs and people who are doing the research, their research questions are driven by clinical need. And the vast majority of what we do clinically is joint disease and essentially fracture biomechanics.
I imagine there must be other areas of orthopedic surgery that you also believe need to be researched further.
Yeah, there absolutely is, and we really hope that this program will embed in the AOVET offerings and in fact expand. And I guess my plea to people who are doing research, residents or AOVET faculty is really anywhere that there's a clinical question, anywhere where there's a knowledge gap, anything that they have a passion in, that they just see this problem on a day-to-day basis, that's what we're interested in. Again, it needs to be clinically relevant, transferable, practical research that will make a difference to how the vast majority of our members who are in general veterinary practice, how they practice on a day-to-day basis.
Mark, this sounds so good. Is anything else similar planned for the future?
Yeah, well, we've got one symposium to go at this point. So once it's all completed and once the dust is settled, we'll have a critical review meeting with the fantastic group in Asia Pacific here who've been driving this forward. And we'll look at the future directions. And we've already had some discussions about whether there's an opportunity to have this as a satellite day meeting to the DeVos courses in future, and hopefully in 2021 that can be face-to-face, but to try and blend both a face-to-face event and an online event and really capitalise on some of the opportunities that COVID have delivered to us, Hannah.
Let's hope so. Fingers crossed for 2021 indeed. Mark, thank you so much from Australia.
Thank you, Hannah.
Hello, my name is Matthew Allen. I'm the Professor of Small Animal Surgery at the University of Cambridge and formerly a member of the working group for the AO Opportunity, Diversity and Inclusion Initiative, the ODI initiative, which hopefully you've all heard about, which has been looking for the last couple of years at issues of opportunity and diversity within the AO. Delighted to say that the outcome of that has been we've identified a number of potential intervention points within the AO Foundation where we can really hopefully improve things. And Access is going to be the vehicle, the new project through which we will deliver the diversity, inclusion, and importantly, mentorship agenda for the future. I'm going to talk a little bit about that, explain the structure, how it came about, and just give you a little bit of an overview of where we're going. So the ODI initiative started a couple of years ago, and one of its key elements has been a survey of AO faculty to determine sort of current status of things within the organization. We've combined that with some existing internal data on representation, for example, of leadership and governance boards. And so we have a pretty good picture of the levels of diversity within the organization. And the data are not that great, to be honest. They're not that encouraging. We have a lot of work to do. But fortunately, we're now able to do that. So we've been able to take the ODI data, which is currently in the process of being written up for delivery as a report to the organization, and also hopefully for publication as well. To take those data and identify a series of potential intervention points. We've also combined that with the mentorship program, which again is felt to be a really critical component of developing the sort of sustainable and really inclusive environment of development of faculty, identification, retention of talent that is so critical to the future success of AO. So the combination of ODI and mentorship under this Access project will allow us, we hope, to create a diverse and inclusive organization with equal access, opportunity, and progression for all. And that is the future for us. It's only through doing that that we feel we're really going to be able to leverage optimally the talent that we have available to us and place the AO at the forefront of medical education and clinical delivery of clinical skills. So the goals of Access are to create a diverse and inclusive organization with access, opportunity, and progression for all. To do that, we're going to use pro-diversity initiatives that have been rigorously evaluated and shown to be effective. We're not the first organization to have done this. We won't be the last. We are in a position to be able to learn from the experiences of others and leverage some of the lessons learned, essentially. We're going to use interventions that are focusing on changing in people's perceptions of what is normal and what should be expected. Essentially, this is a cultural shift. We really need to change our working practices and create an environment which everybody feels welcome, everybody feels valued, everybody feels like they have a place. That's the future. The organizational structure of Access is very lean. It was designed that way. There's very little hierarchy, as you can see from this schematic. The foundation board has direct access to the steering committee. The steering committee is small. It's membership from a representation from the AO Foundation Board itself. And then we have essentially experts from each of the key thematic areas. And then the whole program is then managed by a designated program manager. At the business end of things, we're allocating the tasks according to task forces. There'll be a task force leader and then approximately 3 to 4 task force members. The leaders will have specific experience and enthusiasm and expertise in the topic areas. We'll talk about what those will be shortly. But these are going to be time limited. They will be developed, and once they've been delivered, the task force will be dissolved and replaced with a new task force. So you can see on here, we've got A, B, and C, but futures will be D, E, F, whatever's needed. It's a rolling process. One of the great things that's come out of the ODI report, the survey and the data we've been able to gather from all of you, is a series of really key messages as to where we can make some early interventions, so-called low-hanging fruit. Bear in mind, none of these is going to be absolutely easy, but there are some critical and relatively straightforward steps we can take, ranging from the nomination of individuals through a more transparent process all the way through to the appropriate use of communication and graphics that are more gender representative and more diverse in terms of ethnicity and age. Some relatively simple things that can be really impactful. And the critical thing is that although it's laid out in this way as a sort of as a nice sort of categorical structure where we do A, then B, then C, in reality, a lot of these are going to happen at the same time. There's no point in developing better practices for faculty and leader development if in fact you don't have appropriate language in presentations, gender neutral language and appropriate representation on graphics of a diverse sort of organization that we want to aspire to become. For each of these things, as I say, these are the first 3: faculty and leader development, officer and faculty selection, and mentorship and sponsorship. These are direct outputs from the ODI survey. These were identified as clear and present threats to the sustainability of us as a #1 educational organization within our field. We do not currently reflect the trainees that we're teaching, and we do not currently reflect the diversity of the patient base that we're trying to treat and advise. And this, essentially, through Project Access, this is the step to try and change that for the better. Under faculty and leader development, we're going to make sure, for example, the current existing structures aren't replaced necessarily, but they're supplemented. So, for example, faculty educational programs will now have involved in them elements of recognition of bias. So essentially, gender bias, all of these other things, the so-called unconscious bias that people talk about, these can be trained. People can be given information about how to recognize and manage that, like conflict of interest. We all have these unconscious biases. The issue is to recognize and to have strategies for dealing with that to make sure it does not negatively impact the decisions we make. Officer and faculty selection. We need to see a real change in the way these processes of election are done. They're far too much is done behind the closed doors. The old boys network, it needs to be more transparent, it needs to be more open. Again, other organizations are doing this. We don't have to reinvent the wheel. Mentorship and sponsorship, the critical importance of mentorship in development of young talent. It's not just something that anybody can do. There is, again, a skill set, and we can do better in developing an educational program that focuses on teaching individuals how to become better and more effective mentors. And of course, through all of these interventions, we need to marry not just deploying these strategies, but also an ability to measure their impact and their effects. So we have to know that the strategies we're enacting are actually creating real change. The first 3 task forces have been identified, as I say, based on the ODI data, Additional areas such as, for example, AO staff selection, communication, outreach, collaborations and partnerships, these have also been identified. Others will come along. Through the processes, the task forces themselves will come up with them, and other stakeholders will as well. This is going to be an ongoing process. We wanted to establish and show you the framework that we're working under and really encourage you to become engaged in this process with us. Change is going to require all of us to participate, but it'll be so much better when we have this working the way we want it to work. We all want to work in the sort of environment where we're judged not on any other reason, but by our ability to deliver, our talent, our enthusiasm. That should be the driver for what we are and how we're seen and how we're valued, nothing else. So we encourage you to participate in this. We thank you for your involvement. For those of you who participated in the ODI survey, hopefully this summary of where we're at gives you a little bit of a pointer as to where things are going. Obviously, in the future, there'll be regular updates on how this project is going and what the deliverables are going to be. You'll see this through a variety of our internal communications pathways already. And we look forward to change. Thank you so much.
A lot changes in 60 years, and organisations like the AO and DPS, committed to being at the forefront of education and innovation, change faster than most. Today, this relationship, rooted in shared values, is stronger than ever. We are joined now by Robert Maguire, President of the AO Foundation, Chris Lindenmayer, CEO of the AO Foundation, and Aldo Denti, Company Group Chairman of Depuis Synthis, to gain an insight into what this cooperation means to all of us, especially during these challenging times. Hello, gentlemen. It's great to see you. Thank you for being with us. Bob, if I could start with you, what is the secret to the endurance of this cooperation?
Thanks, Hannah. I think you said we have a 60-year, it's actually a 60-plus year history of interaction and collaboration. So we really kind of know one another. I mean, it's really a unique situation to have had this type of interaction for this period of time. The other thing is we have very similar values and similar vision, which ultimately is the excellence in patient care. We're also both global, and our standards for being able to administer education are very similar. The core really of the cooperation is truly a mutual respect and trust that we have of each other. And the other thing is when we get together, we really have a lot of fun.
I can see that, and everyone's nodding away here as you're talking there, Bob. Chris, how has the relationship between the AO and DPS changed over the years?
So there have been quite a few changes in the environment. One is definitely the increasing regulations in medtech and the ever-growing importance of compliance rules, and with this, of course, more and more influenced by lawyers. The medtech market became much more competitive, and also this has, of course, some influence. Money is not that easily available anymore as probably 50 years ago or so. Then, as Bob has already mentioned, we became much more global. Nobody was talking about courses or educational events in China 50, 60 years ago. And we have also added new specialties, just to mention recon as well as sports medicine. But as Bob has mentioned, thanks to alignment, thanks to mutual respect and also trust, and we know each other very well personally, and this of course helps to cope with all these challenges.
Thank you, Chris. And Aldo, how do you envisage it changing in the future, particularly in the challenging world that we're now in, with digital changes and indeed the pandemic?
Yeah, look, I think, obviously the pandemic has forced all of us to look at how we operate our different functions and businesses in a very different way. And in many ways, obviously, it's made both organizations very, very nimble as we've had to respond to things that we never before had to respond to. Now, the downside is obviously that we've not been able to conduct the kind of education the way we used to educate. But the plus side is that it's actually made all of us lean into this new digital world. And I believe that in the future, this new tool set that we acquired through the pandemic is actually going to be complementary to the tool set that we developed together over 60 years. So when you think about the partnership and the way we've educated over 60 years and the bar of excellence that we've set for both organizations, we're now going to supersede that bar of excellence by adding on a whole new tool set of digital. And I think it's actually going to be incredibly beneficial to both organizations because it's going to expand the scope of what we can do globally in a way like we never could. We were before always thinking about bricks and mortar type of education. Now we can take that and we can expand it and we can expand our reach. And I think as Bob and Chris said, we're going to expand the specialties that we look at, and we can reset the bar for how we want to educate in the future. So I actually think, despite the downside of COVID, it's actually quite exciting for us to look at how we're going to educate in the future.
That's very much the conversations actually we've been having with the surgeons on AOTV this year is saying exactly that. You know, being able to learn like this has opened up so much opportunity. It's exciting. Chris, can I come to you next? How does the CA drive innovation development?
Well, the core of innovation development is definitely our AO Technical Commission. There, under the leadership of the executive board of the technical commissions, quite many specialty groups are working on innovations in many different fields. And of course, on these boards and special expert groups, there are the key opinion leaders of our network, as well as representatives of BPS. So it's really a joint effort to get innovation finally to the patient. Secondly, on the digital side, which became, of course, more and more important, there we do exchange experiences, ideas at very many different levels. And last but not least, I would like to mention ARI, the AO Research Institute, where we do a lot of different research, be it more mechanical, combining mechanical stuff with digital stuff, with electronic sensors, etc., but also research in infections is a very important topic. And I'm very proud to say that in our preclinical research, we of course also do use animals, and we are one of the very, very few institutes globally which have the AAA LAC certificate, which is the highest certificate for research with animals.
That's excellent. And Aldo, can you just take that on a bit further for us and talk about how the AO and DPS work together on this innovation?
Absolutely. Well, look, I think first, it's important to reflect on the mission of both of these companies. We and foundations, of course. We have our motto, as you know, our vision and aspiration is to keep people moving. We have a desire to make the lives of people better across the globe. And you know, DePuy Synthes touches approximately 5.5 million people a year. And that is an incredible barometer of keeping people moving and being able to restore them to what they love to do. So when you think about why we're able to do that, it comes through innovation. And there is no way that a company like DePuy Synthes can innovate unless we have the best minds possible to drive innovation forward. And so this partnership that we have really makes it possible for DePuy Synthes to tap into the brains of the best possible people clinically, which then obviously results in products that are superior clinically, which then benefits obviously more people. And so our aspiration is to continue to innovate in partnership with the AO, to use that expertise and to further the ways in which we can innovate across many more specialties. We've been very blessed to have the opportunity to innovate with in trauma, in animal health, in craniomaxillofacial, in spine. But now, as you heard Chris say, we're going to expand that into other areas, which are going to allow us to look at different ways of solving clinical problems that are still unmet. And that's very exciting. And so I could not be more pleased with the way things are going with our partnership. And I have obviously spent a lot of time talking to both Bob and Chris and many of the other members about how do we actually further and accelerate our innovation pathway. And that is going to continue to be the conversation that we're all going to have as we try and bolster how we innovate in the future, especially considering the advent of digital technology and digital surgery, which is obviously another forefront that we're interested in exploring together.
Excellent. And Bob, how does the relationship, the AO-ITC relationship, bring the power of the AO Global Network with DPS?
Well, as Aldo said, the thing that we can bring to are the expertise of the surgeons and the physicians that are managing the patients. When you're on the front line seeing the real issues, and you look and you say, well, we really need some type of instrumentation that's a little different than what we've had to be able to manage this problem. Let's see if we can take that particular problem and enhance the instrumentation. And so you have this tremendous intellect kind of bank, so to speak, of the surgeons that have been there doing the problem and really realize what is necessary. And so they become really the key opinion leaders of the organization. And by bringing this expertise, we can then get with the engineers from DPS and come up with a really nice way to manage the problem that had not been done before.
And how does this change or impact the patient journey, Bob?
When you look at this particular organization, with it being global, we can, a fractured femur or fractured tibia is the same in South America as it is in North America, as it is in Europe, etc. The fracture patterns tend to be the same. So if we look at standardization of procedures, when you look at it from a scientific evidence-based standpoint, then what we're going to be able to provide is a standard way of managing these particular fractures so that the outcome is going to be very similar regardless of where the fracture or where the injury or the fracture occurs. So I think that's one of the things that the cooperation between the groups allows us to do. It allows that big data, the big data bank that gives us the opportunity to standardize these procedures is phenomenal within the two organizations.
Can we focus now on education? And Bob, coming to you first, where does education sit in the relationship with the AO and DPS?
Well, Hannah, this is the core of the collaborative effort between the two. When you look at education, that is what we're about. And the opportunities that we have between the two organizations is phenomenal. On one hand, you've got the technical aspects that DPS brings. On the foundation side, you have the clinical expertise from all of our surgeons. And when you combine this, it is a huge, huge opportunity to be able to look at the best methods of treatment from the evidence standpoint. And then also being global, we're able to provide this education in multiple formats to all of our members throughout the globe.
So Aldo, how do the AO and DPS make surgeons better surgeons?
Yes, listen, I think we've talked a lot about innovation and the power of innovation, and we've talked about the power of science and clinical expertise. And you can have the best products, you can have the best clinical expertise, but in the end, you need somebody who is clinically proficient. And so when you think about that clinical proficiency and what we're trying to accomplish as two organizations, what we're trying to do ultimately is when you think about, again, I go back to what is our fundamental purpose? Our fundamental purpose is to keep people moving, to restore the quality of life. And so by bringing these two organizations together, what we try and do is we try and globalize the ability for surgeons to up their level of clinical expertise by providing them with the best possible tools to understand how to use the products that we work on together. So what are those tools that we provide? We provide, obviously, anatomical training. Obviously, that is done more on the foundation side than it is done by DPS. We provide tools for surgeons to really look at the clinical aspects of how to actually implant the different devices. So we do that as well. Now we're complementing that with the ability to perfect hand-eye coordination. We're working on assisted reality and virtual reality tools that allow us to do that at a distance as well, to even augment the training beyond bricks and mortar, as we spoke about in before. And I think when you think about the power of these two organizations coming together and taking all of those aspects, the expertise of the foundation, the expertise of DePuy Synthes, and the fact that DePuy Synthes is the #1 orthopedic company in the world with a global footprint, it really allows us to lean in and look at where are the areas in the world where we want to make a difference. And that doesn't always have to be in the places like North America or Europe. We have aspirations to globalize education across the globe. And so together we spend a lot of time thinking about where should we educate? How do we educate? What is the best vehicle for us to accomplish our mission of restoring quality of life? And I think that's the power of this unique relationship, is that we have the same goals, and we identified not only clinical innovation, but more importantly, education as the primary vehicle for us to do that. And that's, I think, an important asset to the two partnership components.
Absolutely. But Chris, what are the biggest challenges we face today in terms of advanced education for healthcare professionals, would you say?
Well, as we all know, the whole healthcare system is under enormous cost pressure. And this, of course, means for the providers, for the surgeons, also time pressure. They need to do more surgeries in a shorter time, and there is much less time available for education compared to 40, 50, 60 years ago. On the other hand, there are very different approaches. You can do just virtual education, like COVID forces us now to do so. Then you can combine it with some simulation. But of course, the ultimate is really the hands-on courses, be it with artificial bones or even with cadavers. And these hands-on courses, that is also the USP of the AO. And unfortunately, due to COVID, we cannot do that now. And having said that, there is also very different preferences amongst the different generations of surgeons. Of course, the elder surgeons, they are usually not so familiar with all the virtual, the digital stuff, so they prefer much more face-to-face education, whereas the younger generations, at least some of them, really love virtual education.
Chris, staying with you, and you mentioned COVID-19 there, the pandemic has, of course, had a huge impact on the way that we live, the way that we work. What is your assessment of the impact on the AO-DPS relationship during this time?
Well, simply said, there have been no more face-to-face meetings. I have met Aldo, if not last December, then probably at the one AO last January or early February in Phoenix. But since then, we have had only virtual meetings. But as Bob has said also in the beginning, as on one hand, we know each other very well, also personally, and there is this aligned vision and purpose and trust, respect, and I would also like to mention fun. And of course, unfortunately, with virtual meetings, fun cannot be lived that easily. Then but there is also a positive side to that. The situation, the COVID situation, has forced us to develop in very, very short time new educational formats. And these formats, of course, they will survive, at least the good ones. But what's a real pity is that our flagship event, this is always these Davos courses with 1,000 or even more participants, they cannot take place this year, and this is a real pity. But I'm very proud to say that the task force, which we put in place in April or May, have been working on a new format, on a congress and the educational events, which is really, I may say so, amazing. But having said that, I still hope that in 21 we can do again the Davos courses face to face and also with some fun.
Most definitely is. It is remarkable what has been achieved, but we do hope to be in Davos for certainly in 21. Bob, coming to you then on that, do you see differences in how the AO and DPS have responded to the pandemic?
No, I don't see really any differences. I think we both responded in a very similar fashion. Both worlds were substantially disrupted, and when you can't travel, you can't have face-to-face meetings, you really have to look at other opportunities. We at the AO had really started looking at digital formats and digital platforms for a lot of our education events that we're going to be doing in the future. And all of a sudden we have the pandemic, and that just really accelerated the need for these digital platforms and to be able to get the education out to our members. And I think the same thing happened, with DPS, and Aldo has already alluded to that. But I think we've kind of done that in parallel. And with our meetings, our JCB meetings, where we have the AO group and the DPS group sitting together, and we do that fairly routinely to make sure that we are in alignment. That is what we've really noticed, and so we're able to use the strengths of each organization to really move forward with this digitalization.
Aldo, what are your thoughts on this?
Look, I think I have to say that I feel very, very fortunate because when you are in a situation like COVID-19 and you have obviously a global pandemic that none of us are prepared for, you really have to think about, well, how do you move a business forward in that environment? And I think I'm very, very fortunate to have in the AO a partnership like I believe is unique in the world. We, most people would say, well, surely there's differences. Actually, there's not many differences. We don't have many differences. So when we had a challenge like COVID-19 come upon us, we actually got together as one unified team and said, how are we going to tackle this? And whether that be keeping physicians safe, making sure we had PPE for everyone, how are we going to make sure that we have the right support for the courses if indeed we're going to have face-to-face courses? Should those be managed locally? Should there be different rules and regulations for some countries versus others, considering that the curves are all different? And I think we had such incredible dialogue. And despite the fact we couldn't meet face-to-face, we found ways to get this all done. And I think when, in my mind, when we look back on this event many years from now, we're going to sit back and be very, very proud of how these two organizations came together with real challenges. And we overcame those challenges in a very constructive way. So I want to say a personal thank you to all of my colleagues that I work with on the AO on a daily basis. And when I mean daily, I mean literally in the pandemic, it was daily. And so I think I have to say a big thank you. It's been a tremendous accomplishment. Are we out of the woods yet? No, we're not. And are we going to continue to collaborate together to find solutions? Yes, we are. But I can, without any doubt in my mind, say that both these organizations are going to come out of this a lot stronger than when we went in. And that, I think, is the plus side.
A massive team effort. Chris, Aldo mentioned there the challenges. What have been the biggest challenges, really, that you've seen because of the pandemic?
Well, as has already been mentioned several times now, it was that we had to switch from one day to the other, from usually hands-on, face-to-face educational events to virtual events, to online events. And you can imagine this involved then a lot of negotiations with hotels where we had already had the reservations, etc., and all the logistics, airline tickets, etc., etc. On the other hand, as also has been mentioned, it forced us to create new formats, and I would just like to mention one where a group, and it was in Spain, tried to combine a virtual course with some hands-on elements, and what they did was they sent some artificial bones, I think it was a pelvis, to all the participants home, because many of them had home office, and so the teacher taught them online, but they could at home do then drilling, etc., on this model. And so it was at least a little bit of a hands-on course. And of course, the other challenge is that we have not met. I mean, I have met Bob and my other foundation board colleagues for the last time last December during the Davos courses. And since then, not anymore. And of course, this makes also the meetings of the foundation board not easier, as very often there are talks, important discussions taking place at the bar on the evening before the meeting.
It's so interesting hearing you say that, Chris. And also, home delivery has really come into its own, hasn't it, during the pandemic? We've all been getting takeaways and getting everything else delivered, but now you can have sin bones delivered to your home too. Bob, if I can conclude with you, and whilst acknowledging the human cost of the pandemic in terms of lives changed and lost, the impact of COVID-19 has prompted new approaches, hasn't it? That there is a silver lining.
Oh, I think there's always a silver lining, and I think the beauty of these organizations, in spite of the real problems that we've had with this pandemic, I think both organizations have seen a silver lining, and that silver lining is a modification of the education format. I think we're really going to see a lot of hybrid courses, as Chris was mentioning, where if the sawbones are sent to the individual, and then all of a sudden you've got the opportunities to do a partial hands-on, that's one thing. We're also vigorously looking at simulation centers to where you can go individually to a center, do a procedure, and virtually. And I think that has also been shown that once you get into anatomical labs and then patient care, that those procedures or the ability to use that particular technique enhances the outcome of the surgical procedure that you're performing on your patient. So again, excellence in patient care is paramount in where we're headed. I think the other thing that we've noticed is that we used to travel a good bit, and I think we've found that some of the travel now we can limit. There's some meetings and courses that we can actually do virtually, which is going to be cost savings in the long run for the foundation. And also from the standpoint of the collaborative effort, I want to say thanks to Aldo and his team for the tremendous support that he's been giving the foundation during this process. We have revamped basically everything that we had done in the past. And as Chris said, we have not had a face-to-face meeting in the last year, but we have continued to get the job done. And I think it really is due to the fact that we work so well together, these two cooperating organizations. So Aldo, thank you very much for the support that you've provided.
A pleasure, Bob.
That has really come across in this conversation. Even though you're apart, you're standing together, and that relationship strength, and indeed the passion in the way that you have all spoken today. Thank you so much, Bob, Chris, and Aldo. We wish you well, and fingers crossed for next year, everyone will be back together in Davos. Thank you.
Thank you.
Thanks, Hannah.
Right, let's find out about the M-Tron and the P-Tron research registry projects now with Ziege Kaslan, Charles Fisher and Larry Rines. Gentlemen, thank you for joining us on AOTV.
Thank you. Thanks for having us.
Charles, let's start with you. Registries seem to be on everyone's lips and agenda at the moment. Why do you need disease-specific registries for research?
Well, Hannah, I think you have to rewind to what the objective of your registry is. Sort of everybody wants to have a registry, and you really have to think about what your goals are. Are they administrative? Are they research? Are they advocacy, quality assurance? And, you know, with our group, the big focus was research. And if that's the case, you really have to go to a registry that's designed to answer specific research questions. If you look to a global type registry, you're going to lose detail. And that's just not going to help you with the specific research questions that you have. So that's why we've focused down in our particular areas of primary and metastatic tumors.
Larry, coming to you next, can you summarize what you've done so far and how does setting up a research registry and collecting data actually work in practice?
Well, it's been a lot of work by a very big group. I think the first thing that we had to decide is what information we wanted to collect. This would seem simple, but everybody tends to want to collect every possible detail, and your database very rapidly becomes unmanageable. So we had to work very hard to decide what questions we wanted to answer, take our core working group, which included surgeons, radiation oncologists, and medical oncologists, and collect data that helped to answer the questions that we were most interested in. Then we had to find centers that had the volume of patients that we were interested in and had the infrastructure to actually carry out the research, and then partner with a data management group that could write the protocols, develop the database, and monitor the effectiveness of the database. And happy to report that our Petron database, which was originated and first enrolled on May 4th, 2016, has already enrolled 762 patients from 16 international centers. Our Mtron database, which enrolled its first patient on September 25th, 2017, has 1,068 patients enrolled from 25 international sites. And very importantly, we've just finished a large project to look at our data collection, to examine it on a center-by-center basis, and try to identify where we have poor compliance and how can we solve those compliance issues. So monitoring the data collection and improving it in real time. And this has caused us to amend some of our protocols and set benchmarks that we can then use to monitor the success of our centers going forward. So it's a continuous and iterative process.
You must be thrilled. What a great result. Well, Zia, can I come to you now? What is the aim of your registry projects and how will they advance the creation of new knowledge and, importantly, patient care?
Well, we would like to really transform the care of patients with both metastatic and primary tumors, and that's the goal of the Mtron and Petron. By formulating specific research questions, we are able to answer some of the treatment challenges that we face in managing these patients, improving their outcomes. And I think that the registry and the way that it is formulated and the way that we pose clinically relevant questions allow us to come up with specific algorithms that would change the field and the care of these patients and improve their outcomes. And I think that the registries, the way that they have been designed so far, proved to be very successful. And I'll be glad to go into some of the specific details how that proved to be the case both on the Mtron as well as on the Petron side.
So what is your vision for the future for the registry, Zia, and for your related research as well?
If you look at, a couple of examples that I can give you what we have accomplished and what is really possible going forward. On the Mtron side, on the metastatic tumor side, we were able to come up with a specific, for example, spinal instability scoring system that is now widely adopted, validated by our group, and widely adopted as a tool that's being used to assess these patients. We came up with a epidural spinal cord compression grading scale that is now widely adopted in managing these patients. And then on the Petron side, or the primary tumor side, some of the molecular markers that we have been able to identify by studying the tissue that we received from various centers, we were able to demonstrate that outcome of chordoma patients, for example, their survival, their recurrence rates are closely linked to having a specific molecular profile. And those are just some specific examples what one can do with using these types of international registries. Above and beyond that, I do feel that it would be great to have built-in AI capabilities so that we can apply machine learning algorithms as we collect the data going forward and refine the patient selection criteria, find new targets to treat these patients effectively, and come up with new ways of managing these patients to improve their outcomes. And then finally, some of the tools that we have developed through the registry, such as quality of life measures and the tools that we have put together, are now being regularly used in managing these patients.
So Larry, talking of the patients, who's taking part in this?
Well, we encourage broad participation, and any interested center can be considered. Obviously, there are some requirements. These centers need to see a high volume of patients with metastatic or primary spinal tumors and need to have some of the infrastructure needed to consent these patients, monitor their data collection, perform the quality assurance protocols that we have in place. As I said earlier, for Pitron, we have 16 international sites, 10 in North America, 5 in Europe, and 2 in Asia Pacific. And for Mtron, we have 25 sites, 15 in North America, 6 in Europe, 3 in Asia Pacific, and 1 in Latin America. So we like our international coalition, and we're always looking for interested sites to be considered to join.
So what data are you actually collecting, Larry?
Well, there's a lot of data that we're looking at. To sort of summarize it, we collect data about the patients, their demographics, their symptoms, their clinical status at the time that they enroll. We collect data about their tumors, the type of tumor, the histology, the location. Is the spine unstable as a result of the tumor? We look at what types of treatments they receive, whether it be chemotherapy, radiation, and surgery. And then ultimately, we look at the outcomes of those treatments. What are the clinical outcomes? And very importantly, what are the patient's reported outcomes? How is their quality of life after these treatments? And the relationship between all of these factors is something we're very interested in. In addition to these basic elements within each of the registries and led by individual healthcare providers with a particular interest, we're trying to answer other very specific questions. So for example, some of the questions specific to our Pitron registry are: what is the impact of surgical margins on clinical outcomes? What are the risks of adverse events? What's the health-related quality of life for these patients after we put them through these big surgeries or extensive treatments? And for the Mtron specific questions, again, adverse events, what are some of the negative things that happen from these treatments, and how can we better avoid them in the future? What's the impact of surgery on keeping these patients ambulatory and mobile? For specific tumor types, are there molecular profiles, as Zia alluded to, that influence outcome? For kidney cancer, what's the impact of targeted therapies, which are very popular in the treatment of that disease? So there are the general data that we collect to answer sort of the general questions about outcomes and quality of life. And then embedded within each of these registries, there are specific questions that we're attempting to answer.
And Charles, what are the advantages and the challenges of conducting a research registry compared to a typical prospective clinical study, would you say?
Well, Larry's already alluded to that a little bit. When you design a prospective study, everything is done a priori. So all your data fields, all the information you want to collect is very carefully thought out, and the process is in place with very specific guidelines to follow up and outcome measures. In designing our registries, we tried to merge the two because registries have a history of failing if they don't have specific objectives or goals. And, you know, the not only the patients, but the investigators or the clinicians involved in these registries need to know the reason they're doing it. And so we, in developing at the initiation period of these registries, had specific questions that we wanted to answer. And we also designed it so that retrospectively we could go back and look at particular questions. They may come up from looking at the data. You know, Zia brought up a number of topics, and that might occur, you know, 2 years into the registry. And so even though it wasn't a specific question at the beginning, by collecting this data, we're able to go back and answer other questions that perhaps we didn't consider at the beginning. So when you design a registry that way, it gives you kind of the best of both worlds. Having said that, you really have to have a commitment to the registry to ensure that we have good, high quality data. Often you go back and you go, I wish I had that. And sometimes you don't, but we've tried to avoid that. I think Larry alluded to earlier, we've just completed a big audit to go back and see where our limitations are, see where our strengths are, so that going forward we can make the quality of our data that much better.
And my final question to you, Charles, as well, is how do these research registries differ from other registries?
Well, we're just highly successful. No, I think the main, well, there's several differences really. We have a very committed group, and everybody is aware of what our objectives and goals are, which I think is really important. Some of the problems with larger, more global registries is people are putting in data and really don't know why they're taking the time to do it. So that's one factor. I think we keep everybody well informed. And the second is, you know, I mentioned this earlier, is we have these objectives or goals that are defined with specific endpoints. So it's like prospective studies embedded within the registry, and having those objectives and goals, I think, really gets people excited to look forward to the results and being able to have an impact on our patient care, as Zia has alluded to. Many of the results of our studies, many of our initiatives have now been adopted worldwide, not only by surgeons but by medical and radiation oncologists. And I think overall a lot of patients have benefited from our work so far, and that's very exciting, and I think drives us for doing more work.
Well, congratulations on what you've achieved with all of those results. It's been great talking to you on AOTV. Zia, Charles, and Larry, thank you very much.
It was a pleasure. Thank you so much.
Thank you. Enjoyed it.
Thanks for having me, Hannah.
Let's catch up now on a live surgical webcast about acute elbow instability, performed by Stefan Ness and moderated by Martin Jaeger. We'll talk through the soft tissue elements to elbow stability, the correct approach to the elbow, and how to plan and perform surgical treatment.
So today's webcast deals with the acute elbow instability and has a special focus on the terrible triad injuries. My name is Martin Jaeger. I'm coming from Freiburg, Germany. I'm working at the University Hospital over there, and my special interest is in upper trauma injury services. I'm today your moderator, and it's my pleasure to work today together with my friend Stefan Ness. Stefan, welcome.
Thank you, Martin. So I'm Stefan Ness. I'm the head of trauma surgery at the University Hospitals Leuven. Also, I have a special interest in upper extremity trauma. I'm very proud to work today with Bettina Broy, who is my scrub nurse, and Alejandro Pacheco from Colombia, who will be my assistant surgeon.
It's a wonderful team. Before we continue, I would like to show our disclosures. And if everything works nicely, then at the end of our webcast, we were proud if you are able to share the idea of a double-guarded fortress if you think about the elbow in order to understand the elbow stability. And at the end, you should be able to describe the importance of bony anatomy to the elbow stability, especially in terms of the coronoid process and the radial head. You should also be able to explain the soft tissue elements which contribute to the elbow stability, such as the capsules, the ligaments, and the musculocutaneous insertions. You should also be able to describe the lateral, anterior, medial soft tissue structures that helps you to choose a correct approach to the elbow. And you should also be able at the end to plan and perform the best surgical treatment of acute elbow instability. Stefan, may I hand over to you?
Thank you, Mort. To make things about elbow instability understandable, we like to introduce the double fortress concept. So we consider the elbow as a donjon. The bony part is the donjon in which a treasure is guarded. And it's guarded by a first circle of soft tissue elements, the ligaments, with the radial ligament complex, the medial ligament complex, and anteriorly and posteriorly a capsule. Around this, and firmly attached to it, there is a second line of defense. It's composed of muscle groups. So on the radial side, we have the common extensors and the anconeus. On the medial side, we have the common flexor and pronator. Anteriorly, we have the biceps and brachialis, and posteriorly, we have the triceps. When confronted to a patient with an acute injury to the elbow, we always have to look whether there is instability that is a part of this injury. To evaluate, we do this in a very systematic way. And we start with the first question, which is if there is a bony lesion to the elbow. These bones, humerus, proximal radius, and proximal ulna, form kind of a donjon in which the treasure stability is kept. Why do I call stability the treasure of the elbow? Because an unstable elbow is painful and therefore loses motion, but also instability is a cause of stiffness. Our body tries to compensate for the instability by rendering the joint stiff, and therefore in a joint like the elbow, for which motion is probably the most important thing, stability has to be considered the treasure. So first of all, we look at the central part. Is there a central bony lesion that jeopardizes the stability? If our distal humerus is broken, we have to fix it. And you can do this either in a 90-90 construct or in a 180 construct, or in the very osteoporotic bone, it may become necessary to use an elbow prosthesis in order to replace the distal humerus. When we look to the proximal ulna, we can distinguish between three fracture patterns. We have the pure extra-articular metaphyseal bending lesions. We have the partial articular olecranon avulsion lesions, and we have the complex articular protrusion injuries. If you want, you can go to the webpage of AO and have a look at on a webinar we had last year on this topic. When we go to the proximal radius, there again we have partial or complete articular lesions, which can be treated conservative, which can be fixed by osteosynthesis, and maybe sometimes we need on-table reconstruction because in situ reconstruction may be too complex, and we'll come back on that later during our surgery. And in some instances, we have to replace the broken radial head. And of course, combination of the different bones can be broken. Then we look at the bony rim. The bony rim, the point of attachment of the primary ligamentous line of defense and of the secondary musculotendinous line of defense. We look at the epicondyles, the medial and the lateral, and if they are completely avulsed fractures, then we have to perform an osteosynthesis of those epicondyles. When we have more incomplete lesions, like chipped avulsions of the musculoligamentous insertion, then we have to investigate their extent. When we turn to the proximal ulna, there the attachment point is the coronoid process. On its medial facet, the medial collateral ligament, or its anterior bundle, is inserted, and therefore it's important. But it's also directly bony important in stability as being a complete base fracture. After judging the bones, we go to the soft tissues and we look at the secondary line of defense, or the primary line of defense, the ligament attachments. And we look whether there are medial and lateral collateral ligament complexes, which are the gates to the injuries, are intact. If one falls in supination on the outstretched arm, depending on whether the arm is in internal or external rotation, we have a primary tear on the lateral medial collateral ligament. If the arm is pronated, then we see the more complex fracture dislocations, which we are going to evaluate today. And then we look at the muscle attachments. Intact muscles may compensate for torn ligaments. So we look at combinations of torn ligaments and avulsed muscles that make the elbow either unstable on the lateral or on the medial or on the anteroposterior direction. And today our focus will be on the terrible triad, a combination injury which is defined by a radial head fracture, a fracture of the coronoid process, and a musculoligamentous avulsion of the lateral stabilizing structures.
Dear Stefan, thank you very much for this structured lecture about the terrible triad. And I ask you to go over to the specimens, and I like to use the time Stefan needs to prepare himself to show you the next steps we plan to do. First, we like to perform a demonstration of segmental cutting of the ligaments of the elbow and to show how the ligaments contribute to stability. After that, I would like to show you today's case, a terrible triad case, which would like to receive a surgery shown by Stefan again. And the surgical steps of that procedure are first the exposure of the lateral elbow and the different approaches, the Kocher and Kaplan approach, the differences between both of them. We would like to show you how to deal with a coronoid fragment, how to retouch it. We would like to show you how to reconstruct the radial head, especially the on-table reconstruction would be a topic. And then we like to restore the lateral soft tissue complex. And at the end, we would like to show you how to check residual instability, and if there's one remaining, how to deal with it, especially if there's a remaining medial instability. After all of that, we will have probably a lot of time for question and answers, so don't hesitate to use your chat room and to give all the way along the questions you're interested in.
So when we have an overview of the table here, you can see that we have an arm on which we already took away our secondary line of defense. In other words, we took away the muscle groups which are attached to the distal humerus, the proximal ulna, and the epicondyles. So now we can visualize, and we can zoom in here on the lateral aspect. We can visualize the radial head, which is when we zoom in here at this point, you can see how it rotates together with the forearm. And then we immediately can see the lateral collateral ligament complex with a annular ligament, which runs around the radial head, with a radial collateral ligament, and most important, with the lateral ulnar collateral ligament, which extends from the epicondyle to the ulnar ridge, and it's like a hammock in which the radial head is stabilized. Anteriorly, and to visualize better, I now am going to take away the muscles. Can I have a knife, Tina? Anteriorly, we will able to visualize the capsule after that I cut through the brachialis and biceps muscles. So when we look here now, we have the anterior capsule, and you can see how, when we zoom in on this spot, how the coronoid process is moving in this groove in the trochlea. Now when we turn more medially, and then we can recognize, of course, the ulnar nerve, which I will lay aside. And then from the anterior aspect of the epicondyle, we see the anterior medial collateral ligament run to the ulna. We see the posterior part of the medial collateral ligament and the transverse part. And when I now move the elbow, you can see how the medial band is tensioned and released during flexion extension, and a similar alternation in tensioning and relaxing can be witnessed in the posterior band. Now when we switch posteriorly, again we can see the capsule as a rather loose structure, which is elastic during flexion extension. And if we switch to the radial side, we can see our posterior lateral ulnar collateral ligament, which runs along and posteriorly to the radial head and is like a hammock in which the radial head is hanging in the good weather summer that in some parts of Europe we are witnessing now. Now, when we look at stability, you can see that pro and supination are tolerated without too much of a problem, and that there is no instability. The radial head remains well aligned to the distal humerus. Now, let's say that we have an injury that starts on the lateral side. So let's cut the lateral ulnar collateral ligament. When we now observe, we see already that the radial head can slide more posteriorly, and depending on the supinated or pronated position, that this happens more pronounced. But still the elbow remains stable and is not, frankly, dislocated. Now we will extend our cut into the anterior capsule, and you see immediately how the elbow drops back in a supinated position, whereas in a pronated position, the elbow regains its normal position. But still, there is no frank dislocation. Now, when we go more anterior and extend our cut, towards the base of the coronoid process, everything becomes more unstable. Here you now clearly can see the base of the coronoid process. When we observe, I can get a dislocation, and of course, when I now cut also on the anterior medial collateral ligament, all stability is gone, and I have a complete unstable elbow, as in a acute dislocation.
We like to shift to another arm, another specimen, in order to show you how we deal with such an injury, highly unstable injury, and how we go through the surgery. And we like to simulate a case which happened in 2008. It's a 50-year-old female physiotherapist who felt on her hand. She had immediate pain and loss of function in the elbow with an additional hematoma. She has no history of any nor medication abuse. The first initial X-rays are the following. They show you a dislocation fracture. Obviously the radial head is fractured. There's a small fragment of the coronoid process, but the whole injury is not so easy to estimate just by the plain X-ray. So our recommendation is to perform a CT scan if possible. And that's the according CT scan. And if we go through all these slices, then I guess that's one of the most interesting ones. And you'll see a very small bony fragment, a chip fragment, it's a avulsion fragment from the lateral collateral ligament. Additionally, you see the fractured radial head. The next are these, and you can see over here the small fragment of the coronoid process, Ogawa type 1, Regan-Murray type 1, I'm sorry. And over here, you see again the avulsed lateral collateral ligament, which is pictured in the circle. And the arrows are indicating an incongruency of the joint line, of the humeral-ulnar joint line, which is a hint for rotatory instability in that case. So in summary, the bony injuries include the coronoid fracture, and we know that the coronoid is an important stabilizer, especially if the radial head is excised. So you should be aware of that lesion and fix it if possible. And the second bony injury is a radial head fracture. And as you all know, there are several treatment options. Mainly it's the resection, the reconstruction, and the replacement. Each of it has pros and cons. And if we run through each of these procedures, then one can say in terms of resection of the radial head that it is, yes, it is easy and cheap. And it has no later radiocapitular arthritis, but it can run into a varus valgus instability and or into a longitudinal instability. The reconstruction is the only modality which preserves the anatomy. And if it is successful, it gives you a permanent solution. But on the other hand, you have the risk of AVN, of implant failures, and of secondary dislocations of the fracture. The replacement is the only modality which gives you an immediate stability. But on the other hand, it's not only expensive, but quite frequently we are watching loosenings And until now, there's no really fitting, matching prosthesis. There's an anatomical mismatch still existing, which may prompt into a secondary arthritis. So there is still a need for reconstruction, and if you're not able to perform a replacement, the on-table reconstruction is still a viable solution, which, and that's the paper of Bussinger, gives, even today, reasonable functional and radiological outcomes.
Thank you for this very nice overview, Martin. So now we go to the second specimen we prepared, and we do not want to show you the surgical incision as we want you to perform it, but we already took down 2 huge skin flaps. Of course, these are not the flaps you are going to create when you perform the actual surgery, but the idea of today is that we make you understand and visualize all these structures that help you. A first remark before we go to work to the elbow. At the end of the procedure, we are going to talk about hinged external fixation as a supplement to stability. And when we work on the lateral side of the humerus, in order to put our shank screws, we may end up in a conflict with the radial nerve. You see how the radial nerve comes from the posterior aspect, crosses over the lateral ridge to go in the distal part of the upper arm on the anterior aspect. So this crossing happens on average 10 to 15 centimeters proximal to the epicondyle. And therefore, it's important to avoid this area of 10-15 centimeters for pin placement. Nevertheless, there is variance, and especially in injured upper extremities. So therefore, I most strongly would advocate to put your pins always in a mini open way where you clearly visualize the trajectory and see that the radial nerve is out of the way. Now, second, we have to choose an approach to the radial head. And we find 2 approaches very often. A first approach is the approach in the Kocher's interval. The Kocher's interval is the interval between the anconeus and the extensor muscles. It's a natural interval. It's an interneural plane. So therefore, it's very nice. You easily can recognize it by palpation. You feel the space between both. When I open up Kocher's interval, and again, I do this in an extensive way, much bigger than what you would do during your actual surgery for the same reasons as mentioned before. When we open Kocher's interval, we can release the anconeus of its insertion on the ulna and then take our extensors more anteriorly. You can see how the radial head rotates. And I can incise my annular ligament. But when I incise my annular ligament, just below this is running my lateral ulnocollateral ligament. And the risk of injuring it is very high. Therefore, a meticulous repair at the end of the procedure is a must. When we want to go to the shaft of the radius, which is laying over here, we can visualize it together. When I incise, you can see how the radial head will come after the incision in the ligament. Here we see our radial head coming, and I can follow it along the shaft so that when I put in a small Hohmann retractor, I can visualize the head and the shaft in a very nice way. We are here in the safe area of the radial head, at least when I put my hand in a neutral rotation. When I would put my plate strictly lateral, it will not interfere with pronation, supination. The disadvantage of the Kocher's approach is that I cannot reach my anterior structures. So apart from the need of a meticulous ligamentous repair, it's impossible to go to my coronoid fragment, which I need to address in terrible triads. Therefore, I only use the Kocher's approach in Mason tree injuries without dislocation and especially without additional injuries to the coronoid process. As if in this case, we have to address more the anterior part of the elbow, we use the Kaplan's approach, which is a more anterior approach between the common extensor and the wrist extensors. So when I release here, and I open the interval, we are way more anterior to the radial head. When we are in the anterior aspect, we always have to think about the posterior interosseous nerve, which comes right here the radial head, which is here, and my nerve, which is laying very close proximity. So when I am going to put in a Hohmann retractor, in order to visualize my radial head and neck, I might put tension on my nerve. When I put the arm in supination, the nerve is much more tensioned than when I put the arm in pronation. So therefore, use this in order to take away the tension. Now, when I want to visualize the anterior aspect, the coronoid process and the capsule, this view still does not give me enough. And therefore, I extend my Kaplan approach in a lateral approach on the ridge, taking all of the extensors, brachioradialis, long head of the wrist extensor, and take down the muscle as one mass anteriorly. And now when I do so, I get a great insight in the elbow, which will be better even if you rotate the arm and put in a Hohmann.
Stefan.
Martin, you have a question for us.
Yes, it's Rafsan. He's asking you, can you please show the danger to the posterior interosseous nerve in the Kocher approach? So now, since we are able to watch at the posterior interosseous nerve in the Kaplan approach, can we just jump back to the Kocher approach and to have a look where it is and how dangerous it is?
Here we have the nerve, and we can follow it distal, and then you see how it's running into the muscle. So when I would put my retractors here in order to visualize the shaft, I may end up in a conflict. When we extend into the shaft, it might come into danger when we extend more distally for longer plates. So it's especially by putting in your retractor that you might jeopardize the posterior interosseous nerve. Now let's switch back to the anterior aspect. So using this approach, again, you very nicely can see the nerve. When we now look here inside, you see the capitulum humeri, you see the radial head at my fingertip, how it rotates, and you see here how the coronoid process moves along with the anterior capsule, which is here. Now, in order to create our injury, we are going to take down the second line of defense and the primary line of defense as one. So I can release already a bit of my tendinoligamentous insertion on the epicondyle. And to make it real, we're gonna take a small ship of bone together with it. This, of course, we don't do during our surgery. This has been done by nature, which created a avulsion of the ligament complex together with a chip of bone. So takes down a little bit more of my tendinous insertion. Good. Now you can see how the radial head kind of dislocates posteriorly because of the lacking posterior elements. Okay, to make the situation worse, we now are going anteriorly, and I have to identify the tip of my coronoid, which is right there. And my capsule will be avulsed together with it and torn. And now I have to break off the tip of the coronoid.
Stefan, can you please zoom in a little to show us the injury, how it looks like right now, the capsule, how did you detach it?
We have the entire muscle ligamentous complex, which is loose. We have the radial head. We have the anterior capsule, which is torn. And here we go towards the base of the coronoid, on which the capsule is still attached. And I will take that down in a ship fracture. So now we have a very unstable situation of a radial
That's
head,
impressive, isn't it?
which has been dislocated.
That's really impressive.
Okay, that's our terrible triad.
Yes.
And a terrible triad really is a terrible injury. If you are going to treat that, you have to tell your patient that he or she is having a terrible injury and that function will be restored, but that it may take more than one surgery
Stefan.
in order to restore it. Yes, Martin, you have a question for me.
Yeah, or please, would you mind to create the injury of the radial head as well?
Now we can go along and create the fracture of the radial head. So what I would do, can I have a small retractor? Okay, can I have a power saw so that I can cut it away? Now, of course, it will not only be a neck fracture that we are treating, but also a articular fracture. And now we will do the final breaking. So now we have our broken radial head, which we will lay aside. We have our broken, can I have pinset, please? Our broken coronoid with the anterior capsule. We have the lateral collateral injury. So a very unstable situation, as you can estimate.
Stefan,
Yes, please,
let's
Martin.
assume that the medial collateral is still intact. And if you try to fix, just try to do so, the lateral collateral one, and we mimic the resection of the radial head, is it really stable? Or how unstable is it?
When we now would say I put back my ligaments without doing anything to the radial head, you see that there still is a huge instability. And it has been demonstrated that in the absence of a radial head, an injury which is about 30% of the capitulum will render the elbow completely unstable. So in these circumstances, doing a resection always will cause secondary arthritis. So in the terrible triad lesion, to my perception, there is no place for radial head resection. Although in a stable elbow, where you have a comminuted fractures and no ligamentous injuries, there was no dislocation, then there still might be place for a resection. In the terrible triad, where you always have had a dislocation, there is no place whatsoever. Now we have to start rebuilding. And the way we do our rebuilding is from the inside to the outside. So to summarize, we have three lesions. From the outside to the inside, we have our muscle ligamentous avulsion. We have our comminuted radial head, and we have our capsulocoronoidal avulsion. So we start with the central injury and we build toward the lateral. So the first injury we are going to address is our coronoid fracture. If you're dealing with a big coronoid base fracture, which you very seldom see in a terrible triad lesion, then you can use screws or plates to fix it. Most often it's more a smaller piece. And in those, we like the transosseous suture to reconstruct it. Now we can have a look at the instruments we use for our transosseous suture management. We drill 2 holes through the ulna, through which we bring straight needles, which we will use as shuttling devices. Anteriorly in the capsule, we lay a strong orthocort or whatever non-resorbable suture, which we will shuttle through the 2 canals in the ulna and make a knot on the bridge on the posterior side. The first thing that I am going to do is to make 2 drill holes that go from straight posterior to the base of the avulsed coronoid. So I will put my finger on the avulsed coronoid and I will drill towards my finger in order to create a tunnel which goes to the base. Of course, you can check under fluoroscopy, but you also on the fingertip you can feel where you are relative to the normal place where it has been avulsed. And we'll create a second tunnel in the proximity . Okay, so now I have 2 tunnels in which I can put in a K-wire not to lose them, at least in one of them, the other one I still visualize. And then I take my straight needle, which I pass into the joint, which I retrieve centrally. And bring it through. And then we do the same with our second straight needle and bring it through also. So now I have 2 shuttling needles. And then what I will do is to go to my anterior capsular fragment, which is right here, through which I'm going to put a separate non-resorbable suture, including my coronoid fragment. Good. Now this suture grips my capsule, and now I have to bring that using my shuttling sutures through the ulna. I take off my needle. I can lay my suture within. Do the same here. Thank you, Bettina. And now when we go posteriorly, I can retrieve my suture and shuttle it through . Just lost one of both, so I have to bring it through once more. This sometimes happens. So let's go back. Yes, please, Martin. Martin,
Stefan,
you have a question?
I just received a question. how to catch the piece in a comminuted cornered fracture. May I also ask you, do you see frequently comminuted fractures process in the terrible triad setting?
In the terrible triad, we don't see those comminuted that often. And even when they are comminuted, as the reinsertion of the capsula is key and not the insertion of the fragment in itself is the key. Even in those, I do not bother that much. It's the capsular reconstruction that helps me to deal with my problem. So meanwhile, we brought through a second suture. Now we have to shuttle our thread. Okey-doke. Now let's slide through in a prudent manner. Okay, so now we have here posteriorly our capsule, and if you see how from a, please, from a loose situation, we bring it back in its normal position and already recreate medial stability by just pulling on this. We will not definitively fix it now, as that would jeopardize my access to the radial head, but we have this ready for later in the procedure. So the next step will be going to the radial head. Of course, this is a simple fracture, a two-fragment fracture, which you could easily reconstruct in situ. But if you have more complex fractures, you can take the pieces to your back table and make your puzzle, reconstruct them anatomically, and then we are going to fix them with headless compression screws. Maybe we can have a quick view at the headless compression screw instruments. As you can see, you have two screwdrivers. One screwdriver that will capture the head and therefore will allow you to get interfragmentary compression, and then a second screwdriver that will help us to introduce the threaded screw head inside the cortical bone covered by cartilage. We start by putting in 2 K-wires. The tips of those are threaded, and I would suggest you to have them in the opposite cortex, because otherwise when you are over drilling, they can follow your drill when you get out of it. This still can happen when you engage the second cortex a little bit less frequently, but still can happen. But therefore have always a K-wire ready to insert instead of your initial K-wire. Okay, now let's measure the length. And when we zoom in on the length measurement device, you can see that I need a 24mm screw.
Stefan.
Yes, Martin.
Meanwhile, may I ask you 2 questions which are just coming in? One is from guest 7 and the other one from Jesus from Ecuador. Both deal with the radial head fragment in cases of severe comminution. What about excision of the head, or what other options do we have if the headless compression screw is not available?
Of course, you can use standard 2.0 screws, and you should bury them slightly. You should countersink them, and in that circumstances, they are as good as your headless compression screws, or almost as good as. There is some biomechanical evidence from Cologne that even demonstrate that these might be more stable in their fixation than some of the available headless compression screws. So meanwhile, we did over-drill our radial head, and now we can insert our headless compression screws. So now I get to the outer cortex, and if I keep on tightening, I get interfragmentary compression, closing entirely the fracture gap, and then I can use my screwdriver, and when the yellow line here on the screwdriver becomes flush with the outer side of the guide, my head will be buried inside and will be disengaged from the sleeve holder. So now we can put in the second screw.
Stefan,
Yes, Martin?
since the second screw is nearly the same, do you mind to come back to this topic of radial head reconstruction or resection? It seems to be very interesting.
Mm-hmm.
And another guest is asking if there are any guidelines which help to decide whether to go for radial head excision or reconstruction.
When there was a dislocation, always do reconstruct. When there was no dislocation and you simply can reconstruct Mason 2-type fracture, you should reconstruct because it adds to the biomechanical stability. Only if you cannot reconstruct and you have the choice between a arthroplasty or a resection, you have to consider this. And there the guideline would be when after you resected the head, there is valgus varus instability, stating that there is a medial ligamentous injury, then you should replace. If you have arguments for longitudinal instability, when you see that the forearm is shifting relative to each other, you should replace. If prior to your surgery, your patient has wrist pain, indicated that there might be an injury to the interosseous membrane extending up to the distal radial ulnar joint, then you should replace. So in most cases, you should replace. The indications for resection are very rare in my hands.
I agree.
So now we have a reconstructed head, and now we have to bring this reconstructed head into a normal relation with the ulna and with the radius. How can I now find easily my rotation, especially when I have a comminution of the metaphyseal area? When we look at the circumference, we see that there is a higher area and there is a lower area. The higher area is the area where it contacts with the proximal radial ulnar joint in the incisura. We may zoom in. So when we look here at our proximal ulna, you see that there is a place to accommodate the radial head. And we should position it in such way that this higher area of cartilage is in contact with that zone. And then we can try to see in a simple fracture how it fits to my radius. Or when I have a comminution, this tip is the only tip I have. Now that I'm rather happy about the positioning, I'm going to transfix it in the proximal radial ulnar joint so that I can align my radius and fix it. To transfix, I take again a 1.6 millimeter K-wire, which I will drive through the radial head in the proximal ulna, and I can look for my final alignment. I should do it in such way that it does not interfere with my plate positioning later on. So now my head is reduced in the incisura, and now I have to go to the shaft in order to reconstruct it. I here see my posterior interosseous nerve, so this allows me to incise my extensor muscles along the diaphysis away from my posterior interosseous nerve, and to visualize the neck, and finally reduce the shaft to the head and look for a plate. Now we can have a look at the images of the proximal radius plating system, please. As you can see top left, there are two types of plates. You have the plate which goes to the diaphysis and the metaphysis, and which amply interferes with our annual ligament. And you have the plate which extends along the proximal radius neck, ready up to the head, and therefore could interfere. And therefore I prefer to use as much as possible independent screws to reconstruct my head, and use the metaphyseal plate to fix the reconstructed head to the shaft. It's an angular-stable plate, and we position this laterally so that during prosupination it will not interfere. The first screw I'm going to position will be in the oblong hole here, so that I can slide and adapt my height, and it will be a non-angular stable screw that I use for these purposes.
Stefan?
Yes, Martin?
There was an incoming question coming from Jordan. It's from Hashem. And he is asking about the angular ligament reconstruction. Shall we do it? Or if we do so, is there a need for lengthening? Because the plates are sometimes prominent.
Therefore, I prefer to use these lower plates to have as little interference as possible. But the annular ligament contributes to stability of the radial head, but is not that important. The important structure is the lateral ulnocollateral ligament. So if you cannot completely close it, it's not really a big problem. Try to close it, but don't overact, and I would not suggest to perform lengthening procedures in primary fracture cases. So now we can go for angular stable fixation of the head relative to the shaft. There may be that there is an interference of your screws to the...
Stefan?
Yes, Martin?
While inserting the screws, another question. What position is the forearm? Is it in neutral position? And what are the safe zones for the plate? Can you please show us?
As I told you before, when the arm is in neutral position, the safe zone is on the lateral side. So now that I transfixed the head to the proximal ulna, I cannot rotate, as my head cannot rotate, but this plate is in, when you see the entire arm, can we have a look at the entire arm, please? So you see that the hand, the thumb is up here, so it's in a natural lateral position, and the safe zone is on the lateral side of the head. So we'll continue by putting some additional screws. Once more. The advantage of having multiple screws that can go in that direction is that when one of the screws interferes with your headless compression screws, you can leave that out. You preferably have 3 screws in the proximal fragment, but even 2 might be enough. If you don't have these nicely pre-shaped anatomical plates, you also can use mini frag plates and screws from the handset, although that might be off-label use. Do we have a third one? Yes, please. So now finally I'm going to put one more diaphysial screw so that the plate also is fixed with 2 elements to the radius. Okay. And let's put in one more diaphysial screw. So now I've an anterior stabilization by refixing my coronoid. I have reconstructed my lateral part of the donjon by plating and screw osteosynthesis of my radius. Now I can remove this transfixion K-wire. Okay. When we now tighten the capsule, you see that it's already much more stable than when the capsule, now I release the capsule, it's very unstable. I tighten the capsule, and it's way more stable. It's not completely stable yet, but it's way more stable. So in order to augment my stability, I now am going to reinsert my capsular ligamentous complex in its natural position. To do so, I will use a bone anchor, and we might have a look at the instruments right now. As you can see, I use for these purposes a 2.9 millimeter resorbable anchor that I can introduce in the anatomical insertion position. I drill to the stop. I then take the anchor, bring it to my drilled position, and with the mallet and some soft blows, I bring it in, open it, take away the anchor, and I have a suture in position. Now I can use 1 anchor, 2 anchors, depending on the situation, in order to recreate my stability. In order to keep my ligament in the right position, I reduce the head, and I might ask Bettina to hold the arm in this position with the wrist slightly extended so that there is no tension on the reconstruction of my capsular ligamentous lateral reinsertion. As there are no needles on this soft tissue anchor, I have to bring them through. Typically, I would use 4 strands of suture going through in order to get enough stability.
Stefan,
Yes, Martin?
during the detachment of the lateral soft tissue complex, I would like to ask you several questions which are dealing with more or less the same topic. There's, for instance, Nicholas from Malawi and some others who are asking about the postoperative treatment protocol and if you do ever give any prophylaxis against heterotopic ossifications.
As you saw, this is a very extensive injury to the soft tissues of the elbow. And an elbow, as we all know, is very prone to stiffness. So immobilization cannot happen. We have to allow the patient to move immediately. And this motion should be pain-free. If the patient is in pain, this causes stiffness, and therefore adequate analgesia is of utmost importance. Now, second part of your question was heterotopic ossification prophylaxis. We all know that the best working drugs for HO prophylaxis are non-steroidal anti-inflammatory drugs, but they have a negative influence on healing. So therefore, I do not use them in the acute stage. If HO happens, and it does not happen that seldom, then we have to go back in after 3 to 6 months and do a reconstruction, a resection of the heterotopic ossification, and therefore an arthrolysis of the elbow.
Stefan, and while you're doing another suture, do you have any tips and tricks if there are not suture anchors available?
Then you can, of course, use transosseous sutures. You make a simple drill hole and bring your sutures through the bone. They are as adequate, if not even more adequate, than the suture anchor, only it has a higher fiddling factor and takes a little bit more time in order to recreate your stability. But it's a very good alternative to the suture anchor. Okay, so now we have the radial head reconstructed. We have the capsular ligamentous complex reinserted. We tension our anterior capsula by making the posterior suture, and I made 2 drill holes here. You can also make 1 drill hole and knot it on a button device. Again, it depends on how much money you want to spend. So we now took all of the elements of our instability. We reconstructed anteriorly the capsule with the coronoid. We reconstructed the radial head. We reinserted the ligament. And if we see now, we see that we have a stable elbow. It does not dislocate anymore. There still is a slight subluxation, slightly, but when I will close my anterior capsule second to it, then I even may overcome this. So do you have some more sutures for me, Bettina? I will take my annular ligament and suture that back in its position. And then I will bring back my muscular capsular mass and suture also this back in its position. Capsule. Bring it here. Reattach it anteriorly. Oh, you can cut. We bring back the muscles, and I will not do the entire suturing, but this adds to stability. So as you saw, we still have some slight shift of the radial head. The osteosynthesis is stable. The ligamentous reconstruction is pretty stable, but there still was a slight shift. And therefore, I might consider protecting my elbow by using a hinged external fixator. So can we have a view on the instruments of the hinged external fixator? You can recognize on the left the Shan screws you're used to use in putting an external fixator. And we will put 2 Shan screws in the humerus, in the diaphysis, out of the way of the radial nerve. And we will put 2 smaller dimensioned pins in the ulna, distal to the elbow joint. The most important is what you see on the right, a hinge. A hinge which will be positioned exactly on the hinging point of the elbow. The hinge of the elbow will be located in the distal humerus. When we look from the lateral side to the distal humerus, we will recognize on the X-ray a circle which corresponds with the circumferential surface of the trochlea and the capitulum. And I'll try to position my tip of my K-wire exact on that position. And to mimic this, we prepared on a other specimen the X-ray views you need. So let's switch to our X-ray views. You can see the circle that I mentioned, which corresponds to the trochlea and the anterior side of the capitulum. And I tried to find the center point of this circle with my K-wire. Let's go to the next image. And when I identify this, and let's now go to our specimens arm again. So we have this point. Now I try to align it, and with a mallet, I will give some soft blows and bring my K-wire in this center point that I believed to recognize. Now let's switch back to our X-ray view. You see, I'm almost in the center, but not aligned to the center, because then my K-wire has to become one dot. So now that I only brought in the tip of my K-wire with some blows of the mallet, I still can bend it around to find the ideal direction. And I will fix it a bit more and look again to the X-ray view. We're almost there. I bend it a little bit more, and let's have the next X-ray view. That's exactly what I want to see. My K-wire becomes one dot. And now I will introduce it deeper in line parallel to the joint space. And again, I will check in the lateral view and in the anterior view. And in the lateral view, let's go back to the previous image. I want to keep this one dot view. And in the anterior view, next image please, I want to be parallel. I can slide my hinge with centrally this piece of metal when we zoom in, which is hollow. I can slide this over my K-wire that is in line with my center of rotation. And when I fix now both legs to a bar which is on 2 shank screws on the humerus and a bar that is on 2 shank screws on the ulna, my hinge will be exactly at the hinge of the elbow. So we'll end our surgical dissection here, and I really want to thank Alejandro and Bettina for their great help in this dissection and surgery to the elbow.
Thank you very much.